I'm a rheumatologist, a physician who specializes in joint disease, inflammation, and long-term musculoskeletal pain management. And after more than 20 years treating patients over 60, I want to share something that most of those patients never hear in a standard appointment. Almost every week, I see someone in their mid 60s or early 70s who has been living with knee pain for years. Not acute pain from a recent injury, chronic pain, the kind that's there when you get out of bed that makes you hesitate before stairs that you've learned to work around rather than through. And in the vast majority of those cases, the management has been the same: ibuprofen when it gets bad, rest when it gets very bad, and vague advice about keeping active. What I want to talk about today is a compound you can add to your daily routine that operates through the same biological pathway as those anti inflammatories, with none of the side effects that make daily NSAID use genuinely problematic after 60. It's not a supplement trend. It's not alternative medicine. It's a bioactive compound with a documented mechanism of action that rheumatologists and pain researchers have been studying seriously for over 2 decades. And the fact that most patients have never heard this explained in clinical terms is a gap I think this channel can help close. If you're watching this, there's a good chance you've been dealing with knee pain for months, maybe years, and you've been told to take anti inflammatories as needed, rest more, maybe try physical therapy if your insurance covers enough sessions. You've done some version of all of that, and the pain is still there. Not unbearable, maybe, but constant enough to change how you move through your day. That's the story I hear 3 or 4 times a week in my office. Patients who aren't in crisis, but who've quietly reorganized their lives around the pain, skipping the morning walk, avoiding certain chairs, thinking twice before any trip involving a lot of walking. Nobody in a 15-minute appointment has ever sat down and explained to them why the knee is doing this, what's actually happening in the joint, and what the research says about daily management that goes beyond taking something when it hurts. By the end of this video, you'll have that explanation, the mechanism, the evidence, and exactly how to apply it. To understand why this matters, you need to understand what's actually happening inside a knee that's been hurting for years. Most patients assume the pain is coming from bone on bone contact, cartilage worn down so far that nothing cushions the joint anymore. In some advanced cases, that's part of the picture. But for the majority of people over 60 with chronic mild to moderate knee pain, the primary driver isn't structural collapse. It's inflammation in the synovial lining of the joint. Your knee is enclosed in a capsule whose inner surface is lined with the synovial membrane. The synovium has one primary job: produce synovial fluid, the thick, lubricating substance that allows joint surfaces to move smoothly and that delivers nutrients to the cartilage, which has no direct blood supply. When the joint is healthy, this system works automatically. You don't notice it. When the synovium becomes chronically inflamed, and in adults over 60 with age related joint degeneration, low grade synovial inflammation is extremely common, everything downstream changes. The fluid becomes less effective as a lubricant. The joint environment turns chemically hostile to the very cartilage it's supposed to nourish. Inflammatory proteins called cytokines begin degrading the cartilage matrix faster than it can repair itself. And nerve endings in the joint capsule, sensitized by the inflamed environment, produce pain that can feel disproportionate to whatever structural damage actually shows up on imaging. This is why a knee can be intensely painful on an x-ray that shows only mild degeneration. The x-ray shows bone and cartilage surfaces. It does not show the inflamed synovium generating the pain signal. Where do anti-inflammatories fit? Drugs like ibuprofen and naproxen work by inhibiting an enzyme called COX-2, which is central to the synthesis of prostaglandins, the signaling molecules that drive joint inflammation. Block COX-2, reduce prostaglandins, reduce pain. The mechanism works. That's why patients feel better on ibuprofen. It genuinely interrupts the process generating the pain. The problem is chronic use. NSAIDs taken several times a week for months or years carry real risks, specifically in the over 60 population. GI damage, the same pathway these drugs inhibit, also maintains the protective lining of the stomach and intestine. Long-term use increases the risk of ulcer and GI bleeding. Cardiovascular risk. COX-2 inhibition affects platelet aggregation and vascular dilation in ways that elevate blood pressure and cardiovascular event risk with sustained use. Kidney function. NSAIDs reduce renal blood flow, and in patients whose kidneys are already working at reduced capacity, more common than most people realize after 60, that reduction compounds quietly over time. The Mayo Clinic and the American College of Rheumatology both recommend that chronic NSAID use in older adults be minimized and monitored for exactly these reasons. So the patient is left in a difficult position. The drug controls the pain. The drug is problematic for daily use, and nobody has provided a mechanism that would help them need it less often. That gap is what today's video addresses. Curcumin is the primary bioactive compound in turmeric, not a herbal remedy in the vague sense, a specific polyphenol molecule with a documented mechanism that overlaps significantly with the NSAID pathway. Curcumin inhibits both COX-2 and NF-kappa B, the master regulatory switch for inflammatory gene expression in the synovium. It also suppresses the same pro-inflammatory cytokines driving cartilage degradation. A study published in the Journal of Medicinal Food replicated in subsequent trials, including research cited by the Arthritis Foundation, found that a standardized curcumin extract achieved pain reduction comparable to ibuprofen over 8 weeks in knee osteoarthritis patients, with a significantly more favorable gastrointestinal side effect profile. These are not fringe results. They're part of why curcumin has moved from the alternative medicine shelf into the serious clinical conversation in rheumatology. But, and this is what most patients never hear, curcumin as it exists in turmeric powder has almost no bioavailability when consumed on its own. You could add turmeric to your food every day for months and absorb a fraction of what your joints need for any measurable anti-inflammatory effect. This is the most common mistake I see. Patients stir turmeric into a smoothie, feel nothing after 2 weeks, conclude it doesn't work, and go back to ibuprofen. The issue was never the compound, it was the delivery. So let me be specific about what the evidence supports and how to use this correctly. The first and most critical factor is piperine. Curcumin absorbed on its own has bioavailability below 5% in most standard formulations. Piperine, the active compound in black pepper, increases curcumin absorption by as much as 2,000%. That figure comes from research published in Planta Medica and has been replicated consistently. Piperine inhibits the intestinal enzymes that rapidly break curcumin down before it reaches the bloodstream and slows hepatic metabolism, giving the compound more time in circulation to reach target tissues, including the synovial membrane. Practically, if your turmeric supplement doesn't contain piperine or specify enhanced bioavailability, you're likely absorbing almost nothing clinically useful. Look for a standardized extract listing at least 95% curcuminoids combined with piperine, often listed on labels as bioperine, or a phospholipid-bound formulation. The dose used in studies showing clinical equivalence to ibuprofen ranged from 500 to 1,000 milligrams of standardized extract daily, not spoonfuls of powder. Formulated standardized extract taken every day. The second factor is dietary fat. Curcumin is fat soluble. It requires fat in the same meal for proper absorption. The studies showing the most consistent results used curcumin taken with food containing olive oil, avocado, eggs, or full-fat dairy. Taking it on an empty stomach substantially blunts the effect. The implementation is simple. Take it with breakfast or dinner, not mid-morning on an empty stomach. The third piece is the combination with ginger. Ginger's active compound gingerol operates through a partially overlapping and partially complementary anti-inflammatory mechanism, inhibiting COX-2 and also a second inflammatory enzyme pathway, 5-lipoxygenase, that curcumin doesn't address as directly. Research published in Arthritis and Rheumatism found statistically significant reductions in knee pain and stiffness with ginger extract versus placebo. When combined with curcumin, the two compounds appear to produce an effect greater than either alone. The inflammatory environment of a chronically painful knee involves multiple converging pathways. Targeting more than one of those pathways simultaneously produces more consistent results. A combined curcumin ginger formulation or standardized ginger extract taken alongside your curcumin is clinically more rational than either in isolation. If you found this useful so far, I'd ask you to subscribe to this channel and leave a like. This kind of specific mechanistic explanation is not what most people walk out of a 15-minute appointment with. If this channel can put that information in the hands of people who need it, that matters to me as a clinician. The subscription costs nothing, and it determines whether the algorithm shows this to the people sitting with exactly this kind of pain. The fourth element is consistency over time. Curcumin is not a rescue medication. It does not produce the rapid relief ibuprofen delivers within a few hours. Its mechanism is the gradual modulation of the joint's inflammatory environment. The timeline is weeks, not hours. The studies showing clinical equivalence to NSAIDs ran 6 to 8 weeks of daily use. Patients who take curcumin for 4 days feel no acute effect and conclude it doesn't work are comparing two different biological timescales. One suppresses the inflammatory signal acutely, the other progressively reduces the conditions generating that signal in the first place. Daily, same time, same fat containing meal. That is what the data supports. The fifth point, and I want to be direct about this, is contraindications. Curcumin has anticoagulant properties. If you're taking warfarin, clopidogrel, aspirin therapy, or any blood thinning medication, talk to your prescribing physician before adding high dose curcumin. The interaction is real and measurable. Similarly, if you have a history of gallstones or bile duct obstruction, curcumin stimulates bile production and can worsen symptoms in that context. And if you're already taking NSAIDs daily under medical supervision, introducing curcumin alongside them without input from your doctor is not what I'm describing. The goal is reducing dependence on NSAIDs over time, not adding compounds without guidance. Now, what I want to address directly is what this dietary protocol does and does not do. It targets the inflammatory environment of the joint, and that is genuinely meaningful, but inflammation is only one dimension of chronic knee pain after 60. The other is mechanical. Range of motion that has gradually narrowed, stabilizing musculature, weakened by disuse and protective guarding, movement patterns that have become compensatory and now load the joint unevenly. Anti inflammatory management, dietary or pharmacological, does not correct those mechanical factors. It creates a better environment in which to correct them. The mechanical work still has to happen. For years, my position was clear: refer the patient to a physical therapist. I was genuinely skeptical of structured programs in digital format. Most of what circulates online in the category of joint health or mobility hasn't been designed by clinicians with background in orthopedic rehabilitation, and I preferred the accountability of an in-person relationship. The reality I kept running into is that a substantial number of my patients over 60 were not going to physical therapy, regardless of how clearly I made the referral. Insurance covered 8 sessions when the problem needed 20. The clinic was 40 minutes away. The copay accumulated. They weren't unmotivated. They were patients for whom the recommended solution didn't fit their actual lives, and insisting on a pathway they weren't going to follow was, in practical terms, leaving them without one. The gap was structural. These patients needed to know exactly what to do on day 1, day 7, day 22, and what to do on the days when pain was worse and they needed a modified approach rather than a reason to stop entirely. Without that structure, even motivated patients defaulted to nothing. What I eventually found, and have been recommending to patients in this profile for some time now, is a program organized in exactly that format. For the knee specifically, the two components I discuss most in these conversations are the illustrated movement library, which provides low load range of motion sequences for the specific joint axes that narrow earliest in age-related degeneration, and the 8-week progressive plan, which takes the patient from wherever they're starting and builds load and range incrementally without requiring clinical judgment from them. The progression is laid out. They follow it. What I've observed, not in every patient, but consistently enough that I've maintained this recommendation, is that patients between 64 and 72 who combine the dietary protocol with 3 to 4 weeks of consistent work in that structured movement framework start reporting a shift in their baseline. Less morning stiffness, more range before the ache starts, a different quality to the first hour of the day, not absence of symptoms, a measurable change in the floor, which for someone managing chronic pain for years is clinically meaningful. The program is educational and structural. It is not a treatment for any condition, and it is not a substitute for clinical evaluation in acute cases, post-surgical situations, or conditions requiring active medical management. But for the patient I described at the opening, as someone over 60 with chronic mild to moderate knee pain, not in physical therapy, managing primarily with anti-inflammatories as needed, it addresses the structural gap I kept observing. The link is in the description if you'd like to review the program at your own pace. I want to step back and address what happens when chronic low-grade knee inflammation continues unaddressed. Not to alarm, but because the trajectory is something most patients are never shown clearly. Chronic synovial inflammation in the knee does not stay contained to the knee. When the joint becomes painful and range narrows, the hip begins absorbing load it wasn't designed to carry chronically. The lumbar spine takes on shear forces from altered gait. Patients who come to me for knee pain often have hip discomfort and lower back pain as secondary complaints. And when we trace the timeline, those problems almost always emerged after the knee problem was established and unmanaged. The pain you don't address in one joint becomes the condition you're treating in three. There is also what I'd call defensive sedentarism, a pattern I see constantly in patients over 65. When movement causes pain, people stop moving incrementally. They skip the walk, they sit more, they avoid the stairs. Each small reduction accelerates the conditions driving joint pain further: loss of stabilizing muscle mass, reduced synovial fluid production, progressive narrowing of range in tissue that is no longer regularly asked to move through its full arc. Within 2 to 3 years of consistent defensive sedentarism, the decline in functional capacity is visible in the clinic. I can tell within 90 seconds of watching someone move from the waiting room to the exam table whether they've been maintaining movement or gradually stopping. The gait, how they lower into a chair, how they rise, it is not subtle. Mobility after 60 is not athletic capacity. It is autonomy, getting out of a low seat without assistance, stepping off a curb without bracing, going upstairs without dread. These are not fitness metrics. They are the daily infrastructure of an independent life. They are built or dismantled in the decade between 60 and 70 specifically. To bring this back to what was covered today, the chronic knee pain you've been managing with anti-inflammatories has a biological mechanism that a properly formulated curcumin protocol addresses through the same molecular pathway, without the risks that make daily NSAID use problematic after 60. Getting the formulation right, standardized extract, piperine, fat-containing meal, daily consistency over weeks, is what separates a compound that produces measurable effect from turmeric powder that doesn't. Tell me in the comments, how long have you been dealing with knee pain, and has any doctor ever mentioned diet as part of the solution? I ask because the answer tells me whether today's content was genuinely new information for you, and it shapes what I cover next. One more thing before you close this. Cartilage is not static tissue. It responds to the chemical environment of the joint and to the mechanical signals it receives from movement, but its capacity to respond, to maintain hydration within the matrix, to resist the degradation that chronic inflammation drives, decreases with each year of sustained inactivity and unmanaged inflammation. This is not a reason for alarm. It is a reason for timing. The window of favorable biological response exists and moves in one direction. What you do in the next several weeks compounds forward. The program I mentioned is in the description. It addresses the mechanical side of what the dietary protocol addresses chemically. Together, they cover what the typical 15-minute appointment almost never does. And what I'm sharing here is education, not a personal diagnosis. If you have a specific condition under active treatment, anticoagulants, a gallbladder condition, a knee being evaluated for surgery, talk to the doctor who knows your history before changing anything in your routine. That is not a formality. It is the responsible instruction. The link is in the description and in the pinned comment. Look at the structure, evaluate it on the basis of what you now understand about the mechanism, and make an informed decision. The patients who do best over time are rarely the ones who started with the most motivation. They were the ones who understood clearly from the beginning why both sides of this problem, the inflammatory and the mechanical, needed to be addressed at the same time. That understanding is what today was for.